Well, good morning. I'm Al Kazniak, a neuropsychologist and professor at the University of Arizona, and I also serve as Chief Academic Officer of the Mind and Life Institute, the co-host of this meeting along with Rockefeller University. I want to offer a very warm welcome. It's so nice to see how many of you are here. We're very grateful for your attendance. And I want to begin by just telling you a few things about the nature of this meeting. But first of all, to note that this is the 25th anniversary of the founding of the Mind and Life Institute, 25 years ago. Mind and Life Institute seeks to understand the human mind and also the potential benefits of contemplative practice through an integrated way of investigation that combines the first-person knowledge from the world's contemplative traditions with the methods and findings from contemporary scientific inquiry. Ultimately, the goal of the Mind and Life Institute is the relief of human suffering and the promotion of human flourishing, goals that it shares in common with healthcare practice and with biomedical research. The speakers and discussants that you're going to hear from today care very deeply about human distress and suffering in illness as well as in the normative challenges that each of us face across the lifespan. And we're going to hear a good bit about that today. As you know, modern biomedical science and evidence-based clinical practice have made enormous contributions toward the alleviation of suffering through development of effective treatments for illness as well as preventative interventions. And many of these advances have emerged through a systematic focus on basic biological processes in response to pathogens and to injury, and the development of interventions that either interrupt pathological processes or facilitate the body's own healing capacity. So the focus and systematic empirical methods of biomedical science are really critical and have enabled those advances. But I think there's also an implicit aspect of the worldview of biomedical science that has often included a divide between the mind and the body. One consequence of that artificial divide, I think, is that it's a frequent experience of patients within our healthcare settings that while their bodies are well attended, their experience of distress, of suffering, and of the consequences of illness and incapacity for their lives in social as well as other contexts get neglected. I think as recent research has demonstrated, and as you're going to hear more about this afternoon, the experience of distress itself clearly changes the brain with consequences throughout the body, and I think that further testifies to the artificiality of any mind-body division. Our vision for today's meeting is one that endeavors to expand the scope of how we think about illness and distress, suffering, and healing. The presentations and dialogues today are going to incorporate perspectives that integrate basic and clinical research with new discoveries concerning the critical role of the social environment and human capacities for resilience, for healing, and even for flourishing, as revealed by modern research on neuroplasticity, a very important part of what we're going to be talking about today. Another very important part of this conversation concerns the contributions from contemplative wisdom traditions that have long been concerned with human distress and suffering, as well as the importance of ethical behavior and the development of mental training practices that have the potential to alleviate suffering. Now, we recognize that these kinds of conversations are often difficult. People in the fields of science and medical practitioners are understandably skeptical about claims that are made concerning the role of mind in medicine and healthcare. And for that reason, we therefore also wish to examine how psychosocial variables and contemplative mental training practices, particularly meditation, are now being rigorously explored within neuroscience laboratories and real-world research settings. These scientific investigations have both encouraged the continuing integration and scientific assessment of contemplative perspectives and mental training practices in healthcare, and also underscore how there aren't any easy answers or panaceas. So that's something we want to really dig into in discussion today. The scientific and clinical experience of our speakers and discussants, I think, is going to offer us, particularly in dialogue with His Holiness the Dalai Lama, a very rich, stimulating, and informative day today. Today's meeting is made possible by the generous support of the Hershey Foundation and the ongoing Mind and Life Institute support of the several generous patrons and sponsors that are listed in your program brochure, several of whom are here with us today. So we're very, very grateful for that. We're also very appreciative of the support and assistance of the private office of His Holiness the Dalai Lama, for the contributions of our panelists today, for the program planning committee members who put this meeting together, and of course for the Mind and Life Institute staff members who have been working very hard to make this possible and who are going to be supporting today's meeting and providing information that you may need throughout the day. And finally, we're very deeply grateful for this wonderful hosting of the meeting here at Rockefeller University, this lovely auditorium, as facilitated by Dr. Bruce McEwen. At this point, I'd like to invite our morning panelists to come on up and take their seats up on the stage. And now it's my great honor and pleasure to introduce Dr. Bruce McEwen, a really creative, prolific, and influential neuroscientist, and one of Rockefeller's very distinguished professors. Bruce?
Thank you very much, and welcome. It's wonderful to see you all here this morning, and it is a great honor for us to welcome His Holiness the 14th Dalai Lama to our university. So we're here today to discuss practices outside the traditional domains of medicine, such as behavioral interventions that are increasingly recognized as having real biological consequences for both the brain and the body, and that synergize with pharmaceuticals and other medical procedures to help individuals deal constructively with their own lived experiences. Now, Rockefeller scientists have a long tradition of being open to learning from those who are caregivers. Now we are gaining a much more sophisticated understanding of the interactions between cognition, emotion, and the brain. We know these are integrated and are finally beginning to understand how this occurs. And today's conversation is a step, hopefully a step in that direction. In recent years, there's been a cumulative interest in ways that contemplative practices may provide emotional and physical benefits. What's wonderful is these theories are now, as you will hear, being supported by science. Which brings us then to the topic of today's discussion. We're so fortunate to be joined by His Holiness the Dalai Lama, who will be arriving soon, and who has embraced and encouraged a dialogue between the scientific and spiritual communities, and who has also engaged personally in many of these conversations and promoted scientific research into meditating practices. So it's now my pleasure to turn the podium over to the moderator for this morning's session, Anne Harrington, a professor at Harvard. Anne?
Thank you very much. It is on. Let me just start by telling you a little bit about the structure of what's going to be happening in both this morning session and in the afternoon session, because the essence of what this is all about is dialogue. So I've just borrowed the watch from my friend Jimmy Holland over here to be timekeeper. There will be obviously some presentations, but they're going to be 10 minutes. Just enough to get some big issues on the table to enable an interesting back and forth. And there'll be two moments of back and forth. There'll be a moment immediately after each talk in which His Holiness will be invited to ask any questions he might have. The speaker might have a question for him. It might open up to the rest of the group. But at that point, you will not yet be involved. We're going to keep the dialogue within the group for that first period. We'll do that for each of the three short presentations. And then we've made available quite a large period of time for an integrated dialogue, both with the panelists and then opening up to you. So there will be microphones that will be available that you can raise your hand and they'll be brought to you. And you can be part of this conversation. And now I think... it's all right. I'm allowed. We can all welcome His Holiness the Dalai Lama into the conference room. Please join me in Your Holiness. I'm Anne Harrington. We met at a meeting at MIT some years ago. I worked on the conference that you participated in. I'm delighted to welcome you. Yes. You remember? Oh. Yes, at her.
Same person.
Same person. Sorry.
Hello.
Your Holiness, in this conference today, in the dialogues we're going to be having today, we're having them at a center that is famous for world-class medical research. And in that context, we are interested in taking a new look at a well-known and very important problem in modern medicine, namely the way in which research based in the laboratory has tended over years, over the generations, to focus more and more attention on the disease that the patient is suffering from and less attention on the patient with the disease, on the person, the suffering person. Modern medicine is often criticized for focusing all its attention on what's wrong with the body and overlooking the mental suffering of the patient who is experiencing a serious disease, his anxiety, his fear of death, his sadness, his distress. Modern medicine is often criticized for not paying enough attention to ways in which a patient's disease affects the rest of a patient's life. What effect is it having on the family, on his capacity to work, on his relationship with his community, on the sense of his meaning of life, and how whether or not he can still help or serve others. For patients, all of these things are connected. The disease, their suffering, how it their larger life. All of these things are connected, but for modern medicine, they often don't seem to feel connected. But we believe that new research in the behavioral sciences, in medicine, may start to be in a position to put things back together again, to reconnect disease, suffering, and life story into a single integrated whole. We believe that new research may be able to help modern medicine better appreciate something that patients have always known, that their disease, their suffering, their life story are all connected. And we believe that we may be able to do this by showing that mental suffering, life story affect the brain, affect the body, are not disconnected from the course of a disease. And we will be presenting research today that talks about this and inviting a dialogue with you about what you see, the benefits, the potential benefits, and challenges here. We're looking forward to exploring all of these ideas with you over the course of an exciting day. And we will begin this morning now by turning to my friend Jimmy Holland, who will talk to you about distress.
Okay. Good morning. Great pleasure to be part of this and to be part of the dialogue and with this wonderful audience who clearly come interested in these issues. My role with you and with the group this morning is to talk about this gap between the laboratory and the clinic. It's a broad one, and I'm going to bring an example from cancer care to talk about. If you look at literature, there are many studies that show that patients do not receive the care that research shows they would benefit from. One study found 55% of patients were receiving less than what guidelines would recommend. So we know that the goal is to bring basic science to clinical application, to everyday care. And it's that clinical side that I represent because I've been at the Cancer Hospital Memorial Sloan Kettering for over 30 years. So I have lots of experience in the real world of that. Oops, I'm caught back here somewhere or other. Sorry. I think it caught on my...
On your hair?
No, it's caught on my something. Caught on something.
Oh, hang on.
Something is not right.
All right.
We don't want to hang anybody here.
I think you're all right. I think
Thank you. Now I'd move my head.
we don't want any
So
medical
I'm gonna come
emergencies
around so I don't
here.
have to move my head quite so far. So I represent the clinical side, the bedside, the real world, and we're going to hear wonderful science today from things that we hope to be coming now. So we would like that distance to be very short between the basic science and the bedside. And if we could take the mouse and just move him and all the equipment and the interpretations over to the human side, it would make it so easy. But that isn't real life. And I'll show you what's real life. Because actually science must move from the basic research, which we sometimes call the bench, through a process of dissemination and then implementation. So we have to get the word out, get it to people, get it to the clinicians, and then finally get it applied as a routine at the bedside. And so that is where we will be concentrating as I talk on this middle area here, dissemination. And actually evidence-based medicine was really established to assure that research findings were getting to patient care, and they've been around for quite a long while. However, findings get stuck. They don't get moved into the arena of care. And so there's now research going into what is behind this. How do we change attitudes? It's a very important new area of research. So I'm going to tell you about a real-world challenge that I've been dealing with, which is bringing science of psychosocial care and issues to routine practice in cancer care. If you think about it for a moment, we've had some difficult barriers. Cancer was considered so frightening that people were not given their diagnosis. So the first barrier was that we could not talk to people unless they knew what their illness was. I was once invited to a hospital to work, and they said, in 1974, you can do anything you want with my patients, just don't tell them they have cancer. So it's pretty amazing that how things were then. So Yeah. So around 1975, patients began to be told their diagnosis, and we began our work in cancer to try to bring psychological, social issues more to the forefront. So we formed this little subspecialty we call psycho-oncology, but it's multidisciplinary, involves psychiatrists, psychologists, social workers, nurses, clergy, all of us together, studying what cancer does to people. What are their reactions to it? And then the other side of it is, well, what do people do to change their risk, to prevent it, or even to survival? So this is a little area that's evolved over the last 30 years. Second big challenge we had was the fact that patients self-report. Patient ability to talk about their symptoms, their anxiety, their pain. That this was not accepted as a valid measure of anything, only what the doctor thought. The doctor thought the patient had very little pain and the patient said it's a lot. They went on the doctor's decision. So there were no rating scales, and so what we had to do was develop some reliable scales with numbers, quantitative scales, so that we could show that if we intervene with a particular thing, anxiety, and we reduced it, we could show that with data, with numbers. So today we can measure these various subjective symptoms, and we have been able to use those scales now to show that interventions like contemplative science interventions really work. But we were hit in the 1990s with managed care. So clinics, hospitals, offices for cancer care have been very busy. People are seen for short periods. And so I think psychosocial problems got short shrift, to put it mildly. And yet the data shows that about a third of people have significant distress at some point in the course of their illness. So I would call this a breakthrough. That in 97 we had a panel that sat down together representing everyone who has an interest in cancer patient care, and we were mandated to find out what is the problem. And so the panel decided that the first problem is nobody likes the word psychological or psychiatric. They're stigmatized words. Oncologists didn't want to ask the patient, how's you're doing emotionally. The patient often would be reluctant to tell the doctor how they felt because, he might think I'm a wimp and wouldn't treat me. So we had this issue, and the panel came up with the idea that if we use the word distress, it's a kind of encompassing word, and that would not be stigmatizing. Because if you think about it, it'd be normal to have, if you have cancer, it's normal to have a level of distress with fears and worries, but that could become severe enough that would require treatment, or it might impede their ability to take their cancer treatment. So if you think about it for a moment, all the things that cause a person to be distressed are really all the way from dealing with physical pain, with fears, with complications, worrying about their family, worrying about how do I find some meaning in my life, how do I find some kind of structure from which I can face this and to face my possible death. How can I find meaning in the life that's now limited? I use this little cartoon because the patient's sitting there with the psychiatrist saying, don't you have anything better to offer me than reality? And so I say to patients, I can't change your reality. We can't change the cancer. But we can make it easier for you to live with it. Mm-hmm. So the next task was, how do we rapidly get the oncologist to identify who is distressed? We noted over the 90s that pain management became much more effective when they began to ask the patient the simple question, how's your pain 0 to 10? If the patient said it's more than 5, then that meant it was an algorithm immediately to look at their pain. We chose that same thing, and we used on your left side here the distress thermometer, a little 0 to 10 scale, which says, how is your distress this past week? mark on this in the waiting room while you're sitting, waiting for the doctor. Mark on this little thermometer. And if they mark 4 or above, we've learned by studying it. Yes, sure. Self-report in the waiting room with a piece of paper. And if they mark 4 or more, then it goes to the next step, which is a guideline that must go to clinical evaluation, be evaluated a little further by the team, and then referred to mental health, social, or pastoral services.
So you just draw on a line.
You draw on a line. And the prior slide showed you could mark off, were your problems spiritual, psychological, family, practical. So what has come out of this is that we have now are asking people that the 6th vital sign should be after pain. We've always had 4 vital signs: pulse, respiration, temperature, blood pressure. Now pain has been added, and we think distress should be the 6th vital sign. So 2 things have happened that have pushed the story along in a positive way that I want to tell you. First was 2005, we have $1 million given to the Institute of Medicine to study why are cancer patients complaining about this and find an action plan for them. So what happened with a year of deliberation by a good committee, multidisciplinary, was that we found evidence-based strong for communication, doctor-patient communication, critical. Psychotherapies of various kinds are effective. Several drugs are work very well. Self-management, teaching people about their disease. And behavioral interventions, many of which would be similar to meditation. But we also begin to see how hard it is for the caregiver, how stressed the family member is as well. Then came along 2008, another major move forward for us, and this was, that came out of that long study, was that the psychosocial domain must be integrated into routine care. And that's the report right there. Care for the whole patient, that's the idea. This is the model which we put together, and you can see it, the treatment plan must include consideration of these problems. But then how do we implement this? We got the idea, we have the guideline, how do we implement it? That's been our next issue, and in this past year, the body that accredits cancer centers, 1,500 around the country, have mandated that to be accredited by 2015, they must have integrated this domain into routine care. So about 2 minutes, 1 minute. 1 minute. It's okay. Okay. So I'm sorry. So we took this to the international community, of which we have organizations in every major country and working in developing countries. And we took this same idea, we said we must integrate it in psychosocial and routine care and make it the 6th vital sign. And I'm going to show you 47 different international cancer organizations that have endorsed this. You don't need to know each one, but it's really quite remarkable the degree to which that has occurred. And we now have a meeting conjoint with oncologists and all of our international group in Australia coming up next month. So I think you have an idea that here's a little bit of a success story. Small, but a good story. And what has happened is that right now, 2012, I think we do have a kind of science of psychosocial care. We have evidence-based interventions, we have guidelines, which creates a science, but the real issue then is making sure that this international standard of recognizing the distressed person, triaging them to care, is the way that we must really move at this point. So I thank you all for listening. Thank you. Thank you. Thank you.
Your Holiness, did you have any questions you wanted to ask Jimmy Holland about what she has just said?
Now it is quite clear, quite evidence, the physical health and mental state
very closely connected.
So connected. Now, I just felt. Now we have to work out the mental state or mental sort of feeling, mental experience, affect physical. How? There must be some bridge.
Mechanism.
I think our practice, now for example, the single-pointed meditation, that's common, Buddhist and also non-Buddhist Indian tradition. So, 당연히 sim 지식을 또 낸 데잖아요. 간송선에 류지 냉엘에 치서치. 된적이 때문에 냐라 류신장다 심신장사에 서도와. 다 간다 디도 돌레인 거. 다디 애는가 흉내 중어 차라셔야 돼. 다디 저지였어요.
So His Holiness was saying that it occurred to him, given the clear evidence we now see in the connection between the state of mind and the actual physical health, it reminds him of the statements that are found in the contemplative traditions, both Buddhist and non-Buddhist Indian traditions, where, for example, as a result of a meditation where you place your mind with single-pointed focus and be completely absorbed on a chosen object, and as a result of that kind of training, there's an understanding that kind of a lethargic aspects of even the physical body can be overcome, and then there's the individual acquires a kind of a suppleness of both body and mind. So already in these texts there is an understanding of a mechanism in the relationship between the state of mind and the physical body as well.
So we usually say, of course, this body itself, the composition of 5 elements. Now there, of course, the physical pain, just to think, or no longer pain, won't help.
Right. Well, David might have something to say about that. He might change your mind.
다원은 삼을 흘려요나 지기 류비 가시고 그게 다 류비 최진 소리 가다 류대와 연구가 다 컨디션 거래 어떻디 다 전화체 와지 진리셔야지
So of course there is definitely a physiological level where there are experiences such as pain. Now, and then for a person to say there is no physical pain would be actually a false statement. But at the same time, we do know that as a result of, say, for example, maintaining a calm state of mind, it has an effect on the overall health of the individual. But and then the question is...
Also, you see the mental state, some kind of optimism. Oh, I will recover. That kind of more... Optimism. It helps.
It does.
You're right.
So now how?
His Holiness is saying that we need to find out what is the mechanism in which this causation is working.
I think here is some explanation in usual sort of yoga practice. The 5 elements, there is grosser level of 5 elements. Now there's the solid and
material
liquid
level, yeah.
And in heat, these things. Then more sort of subtle level, another 5 elements. I think there maybe is a different level of 5 elements. So here then, there also is we usually I describe energy, energy, mind and energy always go together. The energy, of course, literally we say lung.
The literal term that we use is really wind or air.
That's the service.
So, but that doesn't really say much about what the phenomenon is.
Energy is
So the word energy seems to capture the function better.
So without that energy, mind cannot movement. That energy, formless, as like mind, formless, but different function. Mind, awareness. That energy, movement. So there are also different levels. So, I don't know.
I think you do.
I think that was good. Yes.
Your Holiness, there was another question Jimmy wanted to ask you, but I think in the interest of time, I will hold that back and ask it when we have the open conversation, and instead I will invite David Spiegel to continue to open up some of these issues about how to integrate the mind into healthcare. David. It's coming up. There you go.
Your Holiness, it's an honor to be here with you again and to be with this wonderful group of people addressing these questions. And I hope to see whether there's something we can learn from the Western traditions that we have developed of altering consciousness and attention with the great experience that you and the Buddhist tradition have of doing it. And also to address the question that comes from the distress that Dr. Holland talked about, what can we do about it, and what is the connection between addressing the distress and having an effect on the body as well. So the question you asked is exactly the one that I would like to address with you. And I would like to do it in addressing three issues. What we do in support groups for cancer patients. We started some 40 years ago bringing women together who had life-threatening illness and having them share their experience and discuss it. And I will describe what the intervention was. I'll talk about how we use hypnosis to alter pain. And one area where I might disagree is actually you can change the level of pain, the physical pain that you experience using hypnosis. And the third area is then what effects do these interventions have on the actual physical health of the patient. When we met in 2005, you made a comment that has had me thinking ever since, and I think was very important. We were talking about suffering at the time, and we were talking about why might it be that engaging with someone else's suffering when you have plenty of suffering on your own would be helpful rather than harmful. And what you said was, in the case of experiencing our own suffering, there is an element of involuntariness, in fact, a lack of freedom. And when you empathize with someone else's suffering, when you embrace others' suffering, there is a voluntary dimension. In fact, that kind of voluntary action comes on the basis of a choice and also on the basis of a freedom. Because of this, you have a freedom in that also the experience may be painful, but it is qualitatively different from experiencing your own pain. So we have used that wonderful thought of yours to try to understand how we can work with cancer patients in sharing their own pain and suffering, but in a way that is constructive and helpful to them. Many cancer patients suffer with problems like depression, feeling hopeless, helpless, and worthless. And this leaves them in the opposite position from the one you described, where they turn inward. They feel isolated and unworthy. They don't engage with other people. And they don't feel they control their own mental state. Their brain is in a kind of loop where it keeps pointing out the negative and they cannot experience the positive. We have found that this state of depression actually predicts poorer outcome with breast cancer. So on this slide, and I'll have a number of slides like this that are called survival curves, where you see over time how many people die in each group. As the line goes down, more people die. And what you see here in the yellow line is people whose depression at the beginning was getting worse, many years later died sooner compared to those whose depression was getting better. So depression alone is a risk factor for mortality with breast cancer, independent of all the other known risk factors for mortality with breast cancer. What we try to do is help people who feel damaged with breast cancer move from this sense of being mutilated by the disease and its treatment to find a way to transcend it. And when you look at the winged victory of Samothrace on the right, you don't look at it and say, there's a woman who's missing her head and her arms. You see it as an image of transcendence. So how can people do this? So the way we try to address the problems facing these patients in support groups is to address their sense of being isolated by themselves to building new bonds of commitment. And it's very interesting to see how quickly people with the same illness come together and feel a tremendous sense of community and belonging. There's also, your illness becomes an advantage. It's not good to have cancer, but if you have learned something about how to cope with cancer, you then can give a gift to other members of the group in teaching them how to cope better with it. We encourage patients not to suppress their emotions, and I think there is much in the contemplative tradition about being open to whatever feelings come to you and let them blow through you. In a sense, we encourage patients to be open about the expression of their anger, fear, and sadness. Many patients think if I suppress how I feel about cancer, I'm somehow suppressing the cancer, and that is not true. So we encourage them to be emotionally open. We encourage them to face their anxiety about death rather than avoid it, to make it familiar, as you said in an earlier conference, rather than something that they run away from. And as Dr. Holland mentioned, it used to be that we wouldn't even talk about cancer, let alone death, with patients. We now know from decades of work that it helps rather than harms them to be able to face their own death and the death of other people, that they can see it from a different perspective in watching someone else, even though they grieve losses in these groups. Many patients wonder what's left in my life. If I can't have the life I had before, is there any meaning in it? And we encourage patients to reorder their life priorities and find new meaning in it. My mentor, Irvin Yalom, said cancer cures neurosis. You know, when you get that ill, you find ways to redefine meaning in your life. Families are tremendously stressed by cancer, and we encourage patients to communicate more clearly with their families, have them talk about their own fears and concerns. Many patients feel helpless in participating in their medical treatment, and we encourage them to take more control, to communicate better with their doctors. And the seventh thing we do is we use what is our Western meditative tradition of teaching them self-hypnosis to control their consciousness and their pain. So let me tell you a bit about what we found in these groups. When one woman was dying, a member made these cards and circulated them to other members, said, "Dear Eva, whenever the wind is from the sea, salty and strong, you are here. Remembering your zest for hilltops and the sturdy surf of your laughter gentles my grief at your going and tempers the thought of my own." So they found themselves comforted by facing even the deaths of other members in the group. We found that we could reduce their tendency to suppress emotions, so they became more open to their own feelings. That's this black line going down here, that they were more open to how they felt. And despite being more open to their anger, fear, and sadness, they actually became less anxious and depressed over time. So this was a randomized clinical trial. Half the patients participated in the support group, the yellow line. In the green line, the ones who did not, and they became less anxious and depressed, especially to the extent that they could stop suppressing their negative emotions. So giving vent to them actually helped reduce their overall distress. Then we taught them self-hypnosis to help them control their pain. And here, Your Holiness, I would differ a bit in what you said about the pain in your arm. I'm sure it's gone by now. Hypnosis can help people actually alter the pain experience itself, so they can literally learn to feel less pain. And it has a kind of focused attention. You mentioned a meditative practice of specific focus. Hypnosis is like what a telephoto lens is to a camera. You see what you see in the center of your consciousness with great detail. You're less aware of what's going on outside that central focus. So you control the context of experience, focus intently, and you are more likely to respond uncritically to suggestion, to what people tell you. So you can change your experience in a rather marked way. And we have found specific regions in the brain that are involved with the ability to experience hypnosis. And two of them that work together are what's called the dorsolateral prefrontal cortex on the left here, and the anterior cingulate gyrus, the dorsal part of it here.
His Holiness is wondering how the decrease in the actual experience of the pain works here. Is it the case that less attention is paid to the experience of pain, and therefore you feel less acute pain, or is it literally decreasing the actual experience of the pain itself?
This is a very important question, and the answer is, in some ways, both happen. So part of it is that the brain reacts differently, and that's actually this region here, the anterior cingulate cortex here. You can turn down the amount of attention you pay to the pain, but to our initial surprise, the other possibility you mentioned also occurs. So they actually reduce the response of parts of the brain, like the somatosensory cortex that records pain experiences, and deeper structures that do. You actually reduce the pain experience itself. So they literally feel less pain, and it doesn't bother them as much. Two parts of the brain are involved.
So how does that compare to the mechanism of pain? Painkillers.
It's a very interesting question, and we studied that. So we looked at the effects of opiates, for example, because there are what are called endogenous opiate receptors in the brain that help us control pain, as the opiates do. It turns out it's a different mechanism, that you can block the effect of opiates and still get hypnotic analgesia. So it's a top-down effect. It's not a bottom-up effect.
opiate release
and chemical
so because it's a top-down approach, there's also a biochemical processes involved.
We think there are, and we're just trying to figure them out now. But we know that one neurotransmitter seems to be involved, and that is dopamine. Dopamine is a prominent neurotransmitter in these particularly frontal regions in the brain. And there is evidence that people who are more responsive to hypnosis have higher dopamine activity in the brain. And there's even some genetic studies now that show that people with a certain kind of polymorphism in a gene that produces dopamine tend to be more responsive to hypnosis.
Does it vary according to age, the effect of this?
It does in this sense. Children are the most hypnotizable of humans. So all 8-year-olds are in trances all the time.
So His Holiness was wondering, because when you're very generally speaking, children are still in the very active process of growth.
Yes.
So maybe there's less. His Holiness was thinking it would be the opposite, because when you're older, then you have much greater activity of kind of regulation, cognitive control. So maybe this effect could be more pronounced in the adults.
Well, it's a very good question, and for many adults that is true. Many adults retain their hypnotizability throughout their adult life. But the interesting thing is that for children, work is play and play is work. So the two regions of the brain that you see here that involve how we carry out a task and deciding what task is important, that's what these two regions do, work together. And in a sense, there's something childlike about the hypnotic experience that some people retain into adult life as well.
Any shogada what I can do.
Will there be a difference in the hypnotizability between morning and evening in the same
Morning and evening, no, I don't think so, unless you're really sleepy. There is no difference in morning and evening. It's an interesting question, but no. Okay.
More confused now.
Okay.
So David is going to just relatively quickly move through.
So we have found that we can change the pain experience of cancer patients, teaching them self-hypnosis and providing group support. So the green line shows that by the end of the year, the breast cancer patients who were taught this had half the pain that the control group did on the same medications. So it's very effective. So the final question that I'll address briefly is, so what effect does this have potentially on not just how well they live, but on how long they live? And we published a paper in 1989 showing to our surprise that women who were randomly assigned with advanced breast cancer to these support groups lived on average 1.5 years longer than control patients. And you see that here in this survival curve, whereby 4 years... So by 4 years after the study began, all of the controls had died and 1/3 of the treatment group were still alive. It was a big effect. We tried to repeat this 20 years later in another study. We did not see the overall effect, but we think it was because the nature of breast cancer treatment had improved. So there were new hormonal treatments. But the patients who had a certain type of cancer, estrogen receptor negative cancer, who didn't benefit from the hormonal treatments, got the same benefit from being in the support group that allowed them to live longer than the controls. So we think the medical treatments had improved, but the ones who could not respond to the medical treatments did still benefit from the support group. Since then, there have been a number of other studies. There have been 15 randomized controlled trials. 8 of them show that psychotherapy actually improves survival time. And I'm very glad to say that none of them show that psychotherapy kills patients. There are none that show. So the 7 others show no difference. This is a study by Barbara Anderson at Ohio State showing that women randomly assigned with breast cancer to support groups live longer than control patients. And most recently, there was a study in the New England Journal of Medicine with patients dying of end-stage lung cancer. They were given palliative care, their depression was treated, their pain was treated, and the ones who got that lived 2.5 months longer than the control patients. So even at the very end of life, and I think especially when medical treatments are less effective, this kind of emotional support seems to be more effective. So the final comments are that we are trying in our tradition to cultivate compassion, help patients help one another, engage and transform pain and suffering, be open to suffering and distress, but transform it with techniques like hypnosis. And we now have evidence that feeling leads to healing. Thank you.
Now there was supposed to be some question time, but since we took it in the middle, maybe we'll move right on to the next talk, and then there'll be an opportunity. Yeah, well, I'm going to just a moment. Then there'll be an opportunity to do it. So, because Liz is quite far away, Jimmy, maybe I'm just ask you to trade places.
It's a great honor to have this opportunity to speak with you. I come from the National Institute on Aging, where we support research on social, behavioral, economic factors that impact how we age. And our goal really is to maximize the active, healthy years of people's lives. And we appreciate that aging is a full life course phenomenon, and that many of the factors that determine how we age have roots in our early experience and unfold across the lifespan. What I'd like to do in these 10 minutes is try to shift gears a bit from the past two talks that we just had and think about some of the strategies that we might need to use to tackle some of the biggest health problems that I see from where I sit at the Aging Institute may involve moving out of the clinic and into the everyday lives of individuals. And that'll require a kind of a mindset shift, I think, on two levels. First, from thinking about health as something that we just treat in the clinic, to viewing health and well-being as a whole life phenomenon that we shape through interventions in people's everyday lives. And second, from thinking about aging as something to fear and avoid, to seeing aging as a lifelong process, and older age as a time that's full of potential with enhanced well-being, new social roles, and active, productive engagement in society. And I think we are all aware that the population demographics are changing in the world. We're going to have a world filled with older people and far fewer younger people, and this poses really an opportunity to take advantage of this growing older population for the benefit of society. But what I'd like to argue is that there are and I'd also say that there are some very positive aspects about aging that are maybe underappreciated. So, for example,
Oh, that's what that
sorry.
is.
Okay. Okay. Sorry about that. It's probably very distracting. So there's.
We'll give it back to her at the end of the session.
Thank you.
His Holiness was saying that maybe you, for the time being, wear it.
So just to emphasize that there is this great potential, there's quite a lot of psychological research that shows that successful aging is associated with improvements in life satisfaction and emotional well-being, increases in world knowledge and experience, a tendency to come to prioritize social and emotional goals much more strongly, and an aptitude in managing our social relationships. But I think that there are really two major challenges that can undermine our potential to take advantage of this growing older population. The first is around failures of self-regulation, especially around health behaviors that can impact people's lives. And the second is around stressful, isolating, or impoverished social environments. And I just want to touch on these two and then talk about some
self-regulation.
So these data show that, this is from the United States, that poor health behaviors are thought to be responsible for 40% of the preventable deaths in our society, maybe 75% of the healthcare costs. These poor health behaviors like smoking, drinking, poor diet, lack of exercise contribute to chronic diseases like heart disease and diabetes. And they're thought to lie sort of at the root of failures of self-control that people may be exerting. And these kinds of failures of self-control can undermine this sort of advances in life expectancy that we're finding and really ruin the quality of life that we experience in our later years. Failures of self-control often are apparent very early in our lives. You see it in school children who fail to achieve educational outcomes and then fail to get good occupational roles. You see it in addictive behaviors that later in life unfold into full-blown addiction, chronic illnesses, obesity, and all kinds of suffering and distress that may be accompanied with that. These data from the Dunedin longitudinal study followed children from birth through age 32 and show that poor self-control assessed early in childhood was associated with both higher levels of health problems and lower levels of economic success and greater financial struggles. So across a wide range of domains, it's becoming increasingly clear that failures of self-control in personal, social, financial, and occupational spheres are undermining adaptive development and healthy aging for individuals. A second challenge is associated with environments that put people at risk for social isolation or high social stress. The data here that are on the left come from a number of longitudinal studies that, though very different populations, all send one particular message, and that is that the lower the level of social integration or connectedness that people feel, which is measured on the bottom, the higher the level of mortality there is among those individuals. So that low social connectedness is associated with higher mortality across all of these very different cohorts. The risk for mortality of low social integration in this analysis was as high as the risk of smoking, actually. And at the time that these data were published, we didn't really have a full appreciation of what you were talking about earlier. That is, what are the mechanisms responsible for how social connectedness impacts our health? But over the ensuing years, there's been a number of advances, and one particular risk factor for poor health outcomes in older age that has emerged is loneliness. So loneliness predicts increases in blood pressure over time. It's also been associated with poor sleep quality, with depression, and with mortality. So it's important to underscore that most people don't report high levels of loneliness, also older people. But there are trends in our society for increasing numbers of older people to be living alone. And this puts them at risk for social isolation, particularly if they experience limitations in mobility or if their communities don't afford ample opportunities for social engagement. So I would argue that combating environments that put people at risk for social isolation is just as important as combating failures of self-regulation in improving healthy development and aging. But this is going to require this mind shift of taking our perspective about how we deal with health outside of the clinic and moving it into the everyday lives of individuals. And many people now are engaged in novel interventions really aimed to do just that. So most interventions tend to focus on individuals, and many people are working to try to enhance behavioral self-regulation through a variety of forms, both in school. Mm-hmm. Yeah. So we'll hear this afternoon. Oh, excuse me. Oh, okay, I'll get there. So we'll hear this afternoon about some interventions to enhance self-control using contemplative practices. But I'd like to take a few minutes to talk about some of these approaches at these other levels in organizations and in communities that are trying to improve people's health, showing some examples from some of the research that we support at the National Institute on Aging. This first example comes from an area that's a big challenge for working adults, and that is dealing with the competing challenges of managing work on the one hand and family responsibilities on the other. This work-family health intervention goes into workplaces and aims to reduce that conflict between work and family by changing the dynamics in the workplace, by promoting supportive behaviors on the part of supervisors, by putting in place workplace practices that promote a little flexibility between work and family time. They also aim to create a more of a what we call a results-oriented work environment as opposed to a be here from 9 to 5 oriented work environment.
Right.
So the idea is that reducing this work-family conflict will reduce employee stress and improve their health, and then also have other positive consequences for their family members and even for the workplaces. So it may enable the workplaces to retain their employees longer and even improve customer care, for example. So this is still ongoing in 2 industries, but the preliminary pilot data are very promising. What this shows is that managers, and these were nursing home managers, who were rated as very low on work-family balance support, had employees who had objectively larger numbers of risk factors for cardiovascular disease, like smoking, obesity, high cholesterol, high blood pressure. The same study also showed that those with the worst managers slept, on average, 30 minutes less every night. So profound effects on the employee health just from the work environment in which they're living. I want to shift to a second example, and this is about the Experience Corps intervention, which puts older adult volunteers in inner city schools to do meaningful activities like tutoring, working in the library, helping with behavior management in the classroom. Volunteers are given small stipends, which enables the program to recruit poor and overwhelmingly minority people who often aren't reached by our health promotion kind of activities. So researchers at Johns Hopkins University are evaluating the health and cognitive impacts on the older volunteers of this program. And again, this is still in the field for evaluation, but the preliminary findings are also encouraging in terms of cognitive and physical activity benefits and mental health. For example, volunteers in the program are found to watch television 2 hours less per day than they used to. Physical activity is improved simply by having to get to the classroom and get up and down from those little chairs that the kids sit in. And some previous studies have shown that there are some long-standing good effects for the schools. So some standardized test scores have improved, and some schools have reported that the children don't get sent to the principal's office for misbehavior quite as often. So what's also interesting is that I think this has a great success in motivating older people to participate because it appeals to their motives to do something socially meaningful instead of telling them to get out of the house or get more exercise more often. And I think these are just some testimonials from some of the participants, and people can read them for themselves. But I think what they really point out to, and there are hundreds of these on the internet, is that this is a win-win program. It gives the older participants a sense of meaning and purpose in life. It helps the kids to achieve, and it enriches the schools and thereby the community by offering this other role and this other person in the classroom environment. And I think these kinds of what we call spillover effects, consequences beyond the individual who's being targeted by the intervention, can be very difficult to model in cost-benefit analysis of how good a health policy intervention is. But we hope that these kinds of studies that are trying to document these effects will contribute to those discussions in a way. I want to give make two more quick data points to sort of emphasize that we really can't afford not to take this potential of older people seriously. These data from the Rush Memory and Aging study bring home the point that when people lack a purpose in their life, it can have profound health effects. So here on the left, you see that among those individuals, and these were older adults age 70 or older, who started out with lower purpose in life, the rate of their cognitive decline was much faster than for those with higher purpose in life. And similarly, on the right side, those with lower purpose in life had higher levels of disability over time. And there are many other health outcomes, including conversion to Alzheimer's disease, that show the same relationships. The second point is that also the attitudes we hold about aging ourselves can have profound influences on our health. These are data from the Baltimore longitudinal study on aging that show that individuals who held negative stereotypes about aging when they were young, sort of thought of aging as a time of infirmity, disengagement, lack of potential, were more likely to have cardiovascular events 30 years later. So these kinds of negative attitudes of aging, whether we hold them ourselves or are held in society, are very pervasive and can be damaging. And the question is whether if society as a whole and we as individuals held more positive attitudes towards aging, that we could see sort of different sorts of effects. So I've tried to argue that we need a mindset shift, that if we really want to support lifelong health and well-being, we need to think about intervening in people's everyday lives, creating the context that can reduce their stress, enable them to have self-control over their healthy behaviors, and also hopefully strengthen communities and relationships. And that we also embrace a positive attitude toward aging, both our own aging and society's aging, so that we can actually realize this potential. Thank you.
have an opportunity to have a conversation specifically about this talk, but this is also now an opportunity to begin to broaden and engage the panel as a whole, and in short order, relatively short order, to engage the audience. And I'm going to just use sort of moderator's prerogative to maybe address your talk, Liz, but in a way that might also begin to draw in David and Jimmy and Your Holiness. One thing that has just struck me now as you were speaking, and a connection that I hadn't quite sort of seen before, was when you were speaking about the important role that having a purpose, for giving older people a purpose, has on their health and cognitive ability and so on. And it just occurs to me that there's a kind of a common theme across all of these talks here, that we thought that staying healthy or getting healthy is something that we do for ourselves, but it almost seems as if it's a side effect of doing things for others, that it becomes something that happens to us while we're in the busy serving others or engaged in some purposeful life activity. And I wonder, this isn't my data, this is I wonder whether or not there might not be a really interesting thing to just throw out. It seemed to me, Jimmy, when because this then, if this is true, then the ways we begin to think about improving health begin to connect to issues of ethics and service. It becomes a much bigger conversation than we might have even thought. In your presentation, Jimmy, you had your distress scale, and there was a very important part of the distress scale that had to do with the meaning, whether people feel that their life is meaningful. And obviously, David, in yours, it's all, when people come together, the women come to these support groups for themselves, but they come at least as much because they care about the others. And we just talked about yours. So I wonder if, first, Your Holiness, whether you might have any thoughts about this, and then we can maybe open this up to everyone here.
Well, that's my fundamental belief. Beliefs all that.
View,
fundamental view. Taking care about others, helping others, out of sense of concern of others' well-being. The reward to oneself is immense. I was just wondering, many years, I think maybe 10 years ago, maybe, one time in Sweden, one person, you see, he, I think, started one sort of movement, perhaps I think, movement. The retired old people, you see, should carry some work, caring children. So both sides is a benefit.
Yes.
The older people, even myself, you see, when I'm mixing with young students and talk with them, at that moment, I also feel I'm younger.
That's right. That's right.
Then among old people, then something like
so when you mix only with the old people, then it almost feels like we're asking each other a question: who is going to go first?
So then children's side, I think sometimes, even I think there is cases, there are sort of, I think obviously there's such happen. The grandparent, sometimes you see, even sort of more closer, their grandchildren. A parent obviously is some work in here and there. Those retired sort of men and women, they can spend more time with children and play. So they themselves feel something active, life, and something useful, and also passing time very easily. And the children also get, I think, more, sometimes is a maximum
benefit now, experience.
I think affection. And then, say, unlike it is some sort of institution who taking care about children, then person who look after them as a sort of on the basis of salary, sometimes this new person come. Then children, new person as a stranger. But a person who several years was with them, and then the person has got a bond.
That creates a bond. Yeah.
That is some organization who take care about children. They found the consulta 그도 ben 보고 즉 가서 우리 최대한데 지금 보고다 돌로도 즉 칼란스 잘 다도쳐 좀 마인베 즉 정확히 쉽게 해서 버리셨어. 저서 민 요마침 비체 거라 윤칸 링링지게 이나 그 판다샤도 쓰도.
So His Holiness is referred to some organization that have work in South America.
No.
Sweden, where one of the things that they have figured out was that in the caring of children, one important fact is to ensure that the caregivers are not constantly changed.
This is not Sweden. Yes. Now, this idea is from one American lady.
The South America actually, it was what I was thinking of. It's an American. It is an American organization that has work in orphanages in South America. And one thing that they found out that was very important was one of the important factors was to ensure that the caregivers have enough time to create a bond with the child, so that the caregivers are not constantly changed.
And the caregivers benefit.
So at that time, I actually asked one Tibetan in Sweden, please keep close contact with that organization. And that movement can start in India, Tibetan community. Those old people, although they spend whole day om mani padme. No, that also good. But you see, meantime, they can some kind of active role. Much sort of combine that, thinking next life, and meantime, the remaining sort of life, some sort of useful, sort of meaningful life. But then, the Shanghai was a
so he hasn't heard anything back from that person.
So now, your research, you see, these things make known. And not only just to sort of carry research and publish one sort of article, not sufficient. We should sort of
disseminate.
Movement.
We actually need kind of movements to bring it out there.
I think also that the participants often don't recognize the benefit until they get into the situation and realize. So, for example, with that experience, some of the volunteers keep coming back because when they arrive back at the school, the children run up and say, you're here again, I've been waiting for you to come. And that enriches their whole experience. So convincing people of that is very important.
되게 빠르게 because of loneliness, stress,
So His Holiness was, you had an image,
picture, actually, what picture?
When you were talking about loneliness, there was an image of an elderly gentleman, but His Holiness was...
So you mentioned, you see, shorter life.
But
the picture, very old person.
His Holiness immediately felt there was an irony there.
Jimmy, did you want to say something?
Well, I've gotten very interested in older people for, only an intellectual reason, of course. Nothing to do with my own age. However, in working with groups with older people, this issue of finding a reason to be connected and enthusiastic about something. Either it's reading a book or it's talking with one another, it's helping somebody. But if I can help them to find something to connect to that makes life meaningful, worthwhile, purposeful, all those things interact, I think, and overlap. But they all lead to trying to make the most of what life one has left, whatever that is.
I think one of the implications of this discussion is that consciousness is contagious. And so the example you gave of an older person being with a younger person, we change, we're different. We find different feelings within ourselves when we're interacting with a child than we do with an adult. And so it gets me to the question of to the extent to which we think of ourselves as just splendid individuals, or is the human condition fundamentally one of connection? And is the problem that as people get sick, certainly in our culture, they lose their connections? And so I've noticed that in the Buddhist tradition, part of meditation is not simply turning inward, but loving kindness and compassion. And I wonder if you could comment on the importance of the social aspect of mindfulness.
That I always stress oneness of entire humanity. That I feel very, very important, not necessarily believer or non-believer. So actually we are one of the human beings, each of us, one of the human beings of the 7 billion
family.
That's a big human family. So if we remain on that level, then so no barrier. We can easily, as a day, communicate, develop some closeness feeling. Then ready to share. Their sort of happiness is my happiness. Their suffering is my suffering. That kind of sort of concept easily can develop. When we too much emphasis on the level of differences, secondary level, then different nationality, different color, different sort of faith, like that. And within there, rich and poor, and educated, uneducated, and a healthy body, unhealthy body, and lots of the differences. So these additional sort of barrier. I always telling when I give talk, I sort of have the feeling, I'm talking another human being. If, say, I sort of keep some kind of feeling, I'm Tibetan, I'm Easterner, I'm Asian, I'm Tibetan, I'm Buddhist, then immediately you see create some kind of barrier. Then a little bit sort of feeling of distance. That brings sometimes uneasiness or nervous also sometimes. And then also the pretense also come. Of course, one time, Bishop Tutu, we always teaching each other, you see. Very nice person. So you see, sometimes he, of course, he's teasing, not sort of seriously just talking. He's teasing me, you are a Buddhist leader, you should act like more holy. And at the same time, he often described me as a mischievous person. So in any way, say sometimes you see religion, if you too much emphasis on the sort of religious differences, then some sort of some uncomfortable feeling when talk with other sort of a believer like that. Forget these things. At basic level, we are same human being. They want happy life. I want happy life. Emotionally, mentally, physically, we are same. On that level, look. So, I think our attitude. That also, you see, we have to cultivate that kind of attitude from childhood. I think a child, not much concern about differences. so long, play together, smile together, and they feel very happy. They never count, right?
Calculate.
Calculate their sort of social sort of background or all these things. So we must sort of keep that kind of sort of
Spirit.
open spirit. So sometimes I think we can learn many things from children. They're very honest. 좀 잘해. 보고지다 아마치. 제 미잔디 가서 샵된 중이지. 댄디시브리 제리. 아니 아마디 샵된 중에 샵된랑에 댄디시 야이네 샵된랑에 데 르켜란 말도가 아무라. 아니 보고된 나체. 아니 디 샵된 중이디 그냥 꾸부꾸부 들어가 야어때 아슬러래. 아니 보고도 다스때 간도스네 깨져지 샵된 중에 다 돼요. 아무라스 샵된랑에 꾸부꾸부면도 세 깨져.
Tell us what he said.
This is also saying that this reminds him of a story. There was a family with a mother and a young child, and then the mother had invited a monk to the home to perform rituals, as it's the custom in Tibet. But at the same time, the mother did not trust the monk completely. So she had assigned the child to keep an eye on the monk so that he doesn't steal anything. So the child, stood there for a little while, and after a while, he was feeling impatient. He wanted to go, so he shouted to his mother, saying, "Mommy, the monk is not stealing anything."
So children,
They're honest.
very honest. Sometimes see, our education and environment sometimes teach them hypocrisy.
Yeah, hypocrisy.
Got there. Yeah.
If I could change the theme just for a little bit, I want to put one more sort of question on the table for everybody, and then I think we'll turn to the audience. But just one other question, if it's for to get out, because another a thing that people who face life-threatening illnesses and people who are aging face in common is the prospect of their own death. And dealing with death mentally, spiritually, emotionally is, it's well known that in the Western tradition we have a lot of problems with this. David's work in his support groups is partly so radical because, what was seen as so radical in part because he had people openly talking about death, and people worried a lot about what impact that would have on people's mental health. It was felt to be unhealthy to talk about death. I wonder whether, there might be a different point of view from the Buddhist tradition about what is a healthy way to hold the prospect of your own death in your mind, maybe particularly if you're very sick or if you're older. What is a healthy way to engage with one's death? And so I think this has turned out to be a question first for His Holiness, with the hope then that will bring in thoughts from others.
Then, of course, one important part of thinking, mindfulness, actually impermanence. The first teaching of Buddha, Four Noble Truths, then there was mentioned impermanence. So impermanence, two levels: subtle level, momentarily changing; more grosser level, and like that. So, in our daily practice, we have to think more about impermanence, both level, grosser level, and subtle level. So then, the death is almost part of our life. There's birth, there must be death. So, makes deliberately familiar about death. So that, I think, much easier when actual death comes. Those people, then it's those people who avoid even the word of death, avoid. Then sooner or later death comes. Then unexpectedly,
They're taken aback.
Oh. Then, of course, as a practitioner, in my daily practice, the visualization, death process, then intermediate state, then as a rebirth. So Kela also knows that. I think you also used to practice that, isn't it? Your daily sort of practice, or that. So in my case, different sort of mandalas, I think at least 5, 6. So each day during my sort of meditation, this is 6 times death, and intermediate state, and rebirth. So suppose preparing, actual death come. So I don't know how to successful. As the real death come, I don't know. Suppose I'm preparing for that. So through that way, through that practice, actually, you see, control, not death itself, but you see, the process of the dissolution. You see, because you see, you familiarize several years, even you see, when your mind is still fresh, young body, so these familiar, then old age, and particularly at the time of death, your mind automatically, those grosser level mind, because your body becomes weak. So the grosser level mind, also the sharpness of that mind also is weaker. But the lifelong sort of training or familiarize these things, then that particular sort of subject at the moment you can keep sharp mind, right? So the death process more kasoda.
To recognize the processes when they occur.
The dissolution, 8 stages, like that. So that brings possibility at the final, lowest or deepest consciousness or mind occur, then the Tamba Simtuaji.
So to be able to retain the awareness at that moment, when even at the final moment of death.
So in any way, it is better, you see, to think death is part of our life. Sooner or later it will come. Then important is, while we are alive, our life should be meaningful, should be sensible. That means, if possible, help other, serve other. If not, restrain harming other. Then the last moment comes, you feel regret, no regret. I carry my life meaningful way. Otherwise, at that time, I think a lot of also the regret, right? Like that. And then also attachment. Just I met my close friend, you see, who feels some problems, and I told him, we should practice of detachment.
Non-attachment.
The detachment. Now, firstly, our attachment biased. So we have to build the unbiased love or compassion, or perhaps I think attachment. So in order to develop unbiased, infinite love, first we should reduce our attachment towards our own circle. That also is a very, very important practice factor, like that. So in, I think, the secular sense, this also it can be useful, like that. Sometimes attachments to
sometimes in the secular context, when we speak of attachment, we take it very seriously.
So then more attachment, then finally they come more difficult.
In putting together the different things we've been talking about, it may be we can conclude that some of the sources of distress that people might feel at their own death have as much to do with the feeling of distress that maybe they didn't live a meaningful life. They didn't live a full life as it does with the prospect that now they're of the death themselves, that maybe there's a connection between a meaningful life, a fulfilled life, and the efforts to understand what it means, how one can die with less distress at the end.
You raise a very interesting point that has to do with palliative care, and you mentioned earlier the weakening of the body and to some extent the weakening of the mind. The parts of the brain that tend to go first are the parts that help us learn new information, hippocampus, and the parts that we have learned a long time ago, the things we've learned a long time ago, tend to persist. So I think you raise a very interesting point, that if people practice dealing with death earlier when they're more vigorous and healthy, they're more likely to be able to use that experience even at the end of life.
That's right.
So if I could just add that in aging research, one of the really prominent theories that tries to explain why it is that older people come to experience more life satisfaction and prioritize social and emotionally meaningful goals is because they recognize that their time in life is limited. And this is work by Laura Carstensen at Stanford University. And so many of her studies have shown that it's this change in mindset that people have that's somewhat like what you're describing in terms of appreciating one's own mortality, that really shifts people's focus to things that are more meaningful to them. And then the question is, can you move that earlier in people's lives and get that appreciation, make that vivid for people earlier so that they don't sort of wake up one day and say, oh, my life is now short and I have time to catch up.
What we found with older people is that they tend to live more in the now. I live today because I don't know what next week and next month's going to bring, and that may bring with it more attachment to other people because the attachments become more meaningful when you know your time is limited. So I think those are interesting theories and fit in with this whole thing of kind of meaningfulness at the end of life. That wasn't a question, but.
But just there's a lot of research on end of life that's really struggling to figure out how to put into place kinds of practices that honor people's needs for quietude and social connectedness and so on. And there's a lot. The practice doesn't necessarily support that in modern medicine.
Seems much of what we're talking about some people would call wisdom. Do you think this relates to having acquired some wisdom by an older age that gives insights to these things?
Wisdom
is a very difficult term, and we don't know where we would put it.
But I usually feel, or telling these people, human intelligence is something very remarkable. Now, intelligence, you see, can show us or can tell us that even within the emotion, what kind of emotion is beneficial, right?
Constructive.
Constructive. What emotion is harmful, even for our health and relations with our community, with our family members. So all this intelligence, responsibility, and also sometimes you see the emotion, the destructive emotion, also upper hand, right? And control intelligence. Then disasters happen. So more balance And mainly, I think intelligence. It is the responsibility of the intelligence. Is it to
evaluate.
Evaluate our emotion. That either we call wisdom, or I don't know. Sometimes wisdom means
one of the problems with the term wisdom is that sometimes when you use the word, people tend to think it has connotations with some kind of religious ideas, religious concepts.
I think there's a profound lesson in your meditation on death. When you think about Dr. Holland's comment at the beginning that she couldn't even use the word cancer, medicine does not do what you do. Medicine in general encourages people not to meditate upon death, to avoid it, not to face it. And yet our experience is that it strengthens people to be able to share their fears of death, to change the meaning in their life, to grieve losses when it happens. And I think that is one area where your tradition and what we do in medicine really could fruitfully meet, because in most other parts of life, we tell people to plan and prepare for them, learn how to drive a car, learn how to do things. When it comes to death, we don't. And I think that would be a very important lesson for modern medicine.
되게 어리결한 게 아니셔서 또 힘들다해서 해야 되지 이랬더니 나중에 용도를 써야지. 땡아도 남자도 새로운 일 계시잖아요. 또보또미 여치기 봐. 왕식 초지다. 이유를 간 거지. 대어도 저런 건데 이제 동네 초 동네 용도를 써야지. 이유를 간에 폐지를 만들어. 이 시간에도 야나면아.
His Holiness, so he's returning back to the same point that we discussed about the actual reduction of the physical pain, and so as a result of hypnosis. So His Holiness is wondering, because often in the discussions with scientists, His Holiness said that he brings up the kind of the classical Indian, kind of philosophy of mind's distinction between sensory processes on the one hand and processes that are more cognitive and mental on the other, such as thoughts and so on. So, so the pain reduction that you're talking about, would that be more in the distress mental domain, or you're talking about actual sensory level of experience?
Well, I think in a way that's another kind of dichotomy that needs to be broken down, because in fact our brain sensory experience is part raw input and part expectation. It's part what we know. So you look at me and you see a man because your brain knows what a man would ordinarily look like. You don't build up that image right away. So all of our true sensory experience is a combination of perception and brain expectation. And in a sense, that means that the brain can literally change the sensory input. And we have evidence from recordings in the brain that if you hypnotize someone and give them a shock on the wrist, within 1/10 of a second, the amplitude of the brain's response to that shock is reduced. So, in fact, I think the brain changes the sensory experience. It's not simply changing the reaction to the sensory experience.
Then I have one request. Some pain here. Now how to reduce through practice of hypnotize?
I would be honored to hypnotize.
I think I will not be very faithful disciple. Very skeptical.
I have ways to overcome that.
Maybe this is a good moment to now invite the audience who's been patiently waiting to get involved to put some questions, and you're free to put questions to whoever is sitting up here that you'd like. But the only request is to please make them brief and to please make them questions. Yeah. Oh, well, where is the? I actually can't. I did. Where's the microphone? So if you come down here.
There's one right there.
Yeah, go on. Off you go. Let me just get Well, we'll do it we'll take as many as we can. And we're going to go a little bit past 11:30 because we started late, so we'll take the full time.
Your Holiness, I have a question for you about attachment. You speak often about the importance of not having so many attachments. It's such a fundamental part of Buddhist practice. But the research of members of the panel is talking about being integrated into your community, being in the Western mind, we think about that as being more attached. So it's like the science that we've seen this morning is talking, at least as a Westerner, I would think it means to be more attached to your family, more attached to your friends. But that goes against so much of the fundamental teachings of Buddhism. So I was wondering if you could give me your reflections on how to think about attachment.
Thank you. So earlier, now, I think obviously, some kind of attachment, even animals also have that experience. These are biological, not through training. Now, those people who have interest about sort of the universal sort of love, right?
Real compassion.
Universal sort of compassion. That also is the same sort of kasulpena. One aspect of attachment is very closeness feeling, a sense of concern of their well-being. So that part, should increase. Not your own small circle, but then the infinite sentient being. So the normal attachment, biological factor, that's mainly oriented about others' attitude. So therefore, those people, or even animal, nice to you, you develop attachment. But as soon as their attitude towards you change, no longer attachment. No longer love, no longer sort of compassion. So that kind of compassion is hindrance of infinite love. So therefore, the closeness feeling oriented about others' attitude, then here very much sort of directly very much linked with selfish. They very nice to me, so I love you. Your enemy, very bad to me, so instead of love, hatred, anger. Now forget is their attitude, but they also see same human being, same sentient being. They also loves our affection. So on that basis, not their attitude, regardless what their attitude, but as a sort of the person being, no. Or sentient being, and then extend our love, sense of concern of their well-being. That can go towards your enemy. Enemy, their attitude is concerned, negative to you. But still, they also sentient being. They also want a happy life. So, on that basis, we extend our love. That love is not biological factor, but biological factor, love, take as a seed. Then use our intelligence, pros and cons. Then through that way, consider long-term benefit is more important than immediate limited benefits. So like that, you see, the more training, use our intelligence, long-term sort of interest. It's not only just Buddhist practice, but I think common sense. I think think more about others' well-being, regardless their attitude towards you. I think human nature also, you see, have some sort of the ability show our affection to strangers. Right. If the stranger is passing through some difficulties. One time, I think the Second World War pictorial sort of was the magazine. You see, show one, I think, a Greek soldier or something. In any way, it's one soldier the enemy soldier, you see, they falling.
Yeah.
The other soldier, they can. As a sort of one level, the enemy, so have to kill. But on level of human sort of
Human being.
Human instinctive success.
Instinctive human feeling.
You see that person shot, feet falling
down.
So that disregard what is that category. Take care. So that's also you see part of our
nature.
Our nature. Animal, perhaps Rik Mitumbada, Kras didn't Jungiana.
His Holiness is wondering whether this. Although we do see a kind of similar form of altruism in animal within their own species, but he's wondering.
Species on their own
groups. But he's wondering.
But beyond that, I don't think.
We may not want to. We don't have an expert, an animal behavior expert up here, but probably there are people who could talk about it. But I'm going to, if it's all right, allow a couple more people to ask a question. Would you like to ask a question? We'll good. As many hands as I see, I can. If you could, microphone is coming.
Thank you. So many questions, difficult to ask just one.
Well, you only get one.
Okay, thank you. I was hoping that His Holiness and Dr. Nielsen could expand on the notions of self-control. Self-control is... Sorry. Dr. Nielsen, and you refer to self-control as a key part of what you're observing, and of course self-control is a key part of what the Buddhist practices are about, but in I think perhaps a different way. So I'd like to hear more of your thoughts on that.
I could start with the secular perspective of self-control. From a health perspective and a developmental perspective, there's a kind of a growing sense that something like our ability to regulate our behavior, it's been called the personality trait of conscientiousness, the ability to follow rules, the ability to follow through on things and be planful, the ability to regulate your emotions. In economics, people talk about as the ability to put off impulsive behaviors and wait for the future. That all of these kinds of traits have something in common. That's this regulation, sort of a top-down controlling of some impulses that we have that may play out in a whole host of areas in our lives, and many behavioral interventions are trying to figure out, how to intervene there and to promote that. And I think that the challenge is to figure out how to do that. What doesn't seem to work is to tell people they need to, right? Because they recognize that already. But what may seem to work is to motivate people through other routes to do things that would be good for them anyway, but nonetheless still drawing upon these basic faculties that enable us to take more management and own our own behaviors.
Oh, that's entirely sort of right. So actually, the very meaning of self-discipline is self-protection. Of course, there's some sort of religious rule. Then sometimes is for long-term aim. This is sort of discipline as a come. Not because of basis on our day-to-day life or this life. That's something different. Otherwise, it is self-discipline. That also, I think, a long-term best interest for you, for individual. This is certain sort of things should restrain like that. So that also there, a protection of oneself like that. So that. I think even animal, I think to some extent, I think one food there, but you see, we already planned some sort of trickery to catch. Then they're very cautious. the one side, there was the desire to eat using that food, but at the same time, little sort of cautious. So some form of self-discipline
Self-control.
Oh. So our intelligence is much more sort of deeper or wiser. So long-term consequences, negative consequences, and then self-discipline. So self-discipline is protection, self-protection.
So the
We
two agree.
should not misunderstand. Discipline is something religious
idea.
A religious idea, no. And free society means
So one should not misunderstand the meaning of discipline, thinking that in a free society you don't need any discipline or control.
Since Your Holiness, you asked about the interspecies among animals, there are well-documented evidence of mother elephants taking out a small rhinoceros that was found in the mud, of a lioness in South Africa who took care of orphans antelopes, baby antelopes, and in Calcutta Zoo of a tigress who fed little pigs that were orphans. So there are multiple examples also of dolphins saving people who were in difficulty in the sea, protecting them from sharks' attacks even. So there are actually multiple examples of empathy going beyond species.
Oh. There you go. Thank you.
And about the thing what you mentioned about putting the grandmothers, in Nepal we have a project where elderly widows are taking care of orphan street children, and they are so happy together.
Yes.
Thank you, Matthew. I'm going to get this. Sorry, was there somebody? Yeah, I'm going to try to we'll try to come back to you, but just so we're not sort of focusing on too much on one. Yes, the woman with the white jacket.
Thank you.
And if I'm keep an eye on this side of the room.
This is a question to Your Holiness, also to Liz, and I'd also appreciate any other comments on this. And it's related to Liz's statement that we need a mind shift because of the poor social environment we have for our aging members. And so my question is really this: how do we create a mind shift in our culture? And as a result, one example would be to create more richer environments for our elders so that they can be actively and meaningfully engaged in life. Thank you.
The Robert Butler, who was the first director of the National Institute on Aging, said that the biggest problem, or one of the biggest problems, is that we're all in denial of our own aging. And but really, we're facing a huge problem if we don't start embracing that reality. And we should start thinking about what kind of society we want to inhabit when we age ourselves. And I think internalizing that reality of what aging means may help people to maybe catalyze energy towards changing social institutions. I mean, there are many, many groups working to improve existing institutions or develop new kinds of interventions. But for those things to gain traction, I think a cultural mindset shift that doesn't sort of promote a lot of anti-aging formulas all the time, but thinks that aging is something that is natural and will happen to every one of us. We'll all be young and we'll all hopefully be old, and we should embrace that, I think, and maybe that will help.
There's an issue around stigma that implicit. You talked, I think, at some point in your talk about stigma, and this has come up. That is there something about also overcoming stigma toward that we have towards aging?
Well, I think that people have misconceptions that people may have misconceptions that our old years are times of infirmity, and that most people are living in nursing homes, and many will be, and that's also something we have to grapple with. But most people will be in the community. Most people will not have dementia or serious disability. I mean, we're seeing improvements in medicine have actually been responsible for many of those kinds of delays. So if we have an attitude of about aging and what it's like to be old that's really at odds with the reality, we also need to know more about the facts.
Yes, and then the woman who's sitting patiently on the steps. But we're going to take this gentleman next. Where is the microphone? If you could just stand up so they know that. There you go.
First of all, that was a wonderful panel, and thank you guys so much.
Thank you.
Dr. Spiegel, this question is for you. It's a brain question. You mentioned the dorsolateral prefrontal cortex as being involved in this hypnosis business, and that makes sense in terms of deployment of attention, cognitive control. That's a good story. The problem, the question is, it seems like there's this component of suggestibility that you talked about, right? Where people could be persuaded that things are true whether they're true or not, and they could be made to feel true. And that seems distinctly different from something like focused attention meditation, right? Because here the rational faculties are actually enhanced. And so we can deliberate on things in ways that are very, very clear for long periods of time. So I guess the question to you is, how do you think there's a way to distinguish between them, and is there an interesting story there? And what do you think that story is?
Thank you. It's obvious that I didn't hypnotize you because you're not being suggestible at all. But it's a good question and an important one. What we showed in this study, which involved hypnotizability, not being hypnotized per se, is coactivation of the dorsolateral prefrontal cortex with the dorsal anterior cingulate. Now, the anterior cingulate does something different. It isn't thinking through a problem. It's thinking what is a problem, or what do I need to pay attention to, and what can I forget about. And I think where it happens in hypnosis is that you narrow the range of attention. So you stop thinking, who is this person who told me to do this? And what does he know? And why should I do this? Will I feel silly if I do? Will it help me or not? So it's not that you couldn't think about it. It's that you narrow the domain of things you think about. You're less likely to contrast and compare, and more likely to engage yourself in the content. It's like being so caught up in a good movie that you forget you're in a theater. You enter the imagined world. So it's not a loss of critical judgment. It's a reduction in the domain in which you would exercise it.
We're going to take.
We're
going to take one more question for His Holiness, and then he has to go. But there will be another opportunity in the afternoon. I apologize. I know there's just not enough time, but there'll be another opportunity in the afternoon for asking questions. So, Jeff will, I guess, take the last question. Where is the?
Jeff, right? Yeah, where's the mic?
Thank you. Thank you. It seemed that a common feature across the different activities and interventions that were described by Drs. Nielsen, Spiegel, and Holland were, whether it's in sustaining healthy aging or interventions to mitigate the stress of disease, was the encouragement of positive emotions. And so if that would be the kind of the core substrate, I guess the question is how can those be sort of developed, or how can activities, or how can behaviors be taught that encourage positive emotions? And I'd be interested as to whether His Holiness believes that that is really a central element in terms of being facilitative of healthy living as well as adapting to disease.
So that's the key factor. I think not only in modern time, but last, I think, 3,000 to 4,000 years. This is I think mainly religious sort of the group always talk about the importance of compassion and the sense of brotherhood, sisterhood. But of course, millions of people, I think, got immense benefit, but world not changed. So in modern time, I think some small organization here and there making sort of effort, I think won't much effect. The only thing is through education, global sort of education system. I'm not talking about religious matter, religious topic, simply Nowadays, you see, how to build a healthy society, happy humanity. So now, that I usually call secular ethics. So secular ethics, no difficulties to introduce in secular education field.
System, no.
So actually, so some people actually is working how to introduce in education field some education about importance of warm-heartedness, sort of with a lot of explanation, and mainly now, like you see your sort of scientific findings. So I think possible. So that's the only way. I think education, because of the universal.
Universal.
If we, because of the based on religious sort of belief, then no matter one religious tradition is something very marvelous, but never be universal. So we need the secular way to educate people. Their sense of concern of others' well-being. Another word, compassionate sort of attitude. It's your own the best interest, most effective sort of interest. So we can teach them through scientific sort of findings. And as Canola mentioned, instinctively the seed is there. So then further sort of the information and give more material, use our intelligence, then that brings conviction, that transforms our behavior. And one individual sort of behavior, there's a change through education. Then, because of that, 10 people, 100 people, 1,000 people, 100,000, million, billion, go like that. So that's the only way. We have to find ways and means to introduce in modern education system. That must be strictly secular approach. I think that's very, very possible. Very possible. So I think with help of these scientists you are finding, then if we make attempt, as the firstly, the also experimentally, say some school carried that sort of curriculum. We'll see after 5 years or 6 years if some definite sort of impact, positive impact on their mind, then can extend 100 schools. Like America, I think then eventually the state level, you can introduce that. Then federal level. Then like United Nations. And then all other sort of all member of the United Nations. So we need this convincing sort of
material.
Material. And I think we can do. And although our organization, Minded Life, a young organization, now within last over 20 years, you see, a small sort of institution now seems to grow quite well. so now it sort of start in America, now go to Europe, and then different countries in Asia, like that. I think we also can make some significant sort of contribution. Now I think maybe up to now we researching.
Up to now we have been focusing more on basic research.
Now maybe time come on the basis of our finding through research. Now, how to introduce, how to implement to actual sort of the effective way to humanity. I think possible. So like that. So the result.
Get a picture together.
Only.
Picture? Sure. That'd be great.
Thank you.
Thank you.
Thank you. Thank you.
Now that's the thing.
Oh, yeah.
Thank you.
Thank you very much.
Bye-bye. Oh.
Thank you.
Thank you.
So friends, His Holiness will go, but we will reconvene at 1:30. We're giving you an relatively generous lunch time to go find yourself something to eat, and we'll be back here for the second session.
Thank you.
Thank you very much.
Thank you again.
Thank you.